More than 20% of patients require IV fluids. More than 40% of patients require x-rays. 80% of patients have at least one medication given or prescribed. Nationally, 14% of patients are admitted to the hospital. And I think Bob has pointed out to you already that we're verging on 2.5 to 3 times that number at Stanford. And the reason we're so high at Stanford is that we see a particularly high acuity of patients. We have very complicated patients. We're a referral center, and so we see just a lot of sick people. This last fact is really important. 90% of level 1 trauma centers, which is the highest level, so this is where you go if you're really banged up, and hospitals with more than 300 beds operate above or at their capacity. So they're already as full as they can be. So that means that the hospitals are full, and when patients get admitted to the hospital, if a bed's not available, they stay in the emergency department. So it's been recognized that there's actually a national crisis in this country in emergency care. And here are the features. The ER is generally accepted to be the place that Americans turn to first when they need immediate medical attention. So just think about it. Where would you go if you really got sick and it was the middle of the night? Is there any other place that you can go? Emergency departments across the country are overcrowded, and therefore, unfortunately, from time to time, ambulances are turned away. And so we hate to do it. It runs against the grain of everything we've been taught and trained to do, but there are times when our capacity is such that we have to not take ambulances for a period of time, and that's just a fact. Admitted patients in most hospitals wait in emergency departments and hallways for hours, sometimes for 12 or 24 hours, until an inpatient bed can be found. Critically ill patients wait the longest because of the shortage in intensive care unit beds. So again, this all points to capacity constraints. So there's a shortage nationwide of ER and certainly of ER psychiatry beds. All right? That's a very big problem. It's not uncommon for physicians in emergency departments to have to board patients for up to 2 days until they can find them an inpatient psychiatry bed because there just aren't enough beds. Sometimes specialists, now we do not have this problem at Stanford, so this is a nationwide problem. Sometimes specialists are not available. We're very fortunate to be at Stanford where we have superb support from our consulting services and where we can get to neurosurgeons and plastic surgeons and cardiologists and neurologists very quickly. But people in the rest of the country are not so lucky. Emergency departments provide much of the care for the uninsured in this country. But emergency department users are as likely to have insurance as to not have insurance. But they're more likely to have poor mental or physical health or to feel disenfranchised by the healthcare system. So it's a common misconception that emergency departments are inundated with people that are uninsured. Certainly in some inner city situations that is the case, but as a general rule, it really is people that just don't have any other access to care, not necessarily that they don't have funds. Physicians and offices are becoming a little more timid. They won't take the risks associated with doing procedures. They won't accept the risks associated with hanging on to patients who might be seriously ill. So if someone is in a doctor's office or in an urgent care center and they're deemed to be potentially seriously ill, they immediately get sent to the emergency department. We have a lack of disaster preparedness related to resource constraints. It's one thing to think about what we would do in a disaster if we had 15 or 20 people, but think about a pandemic situation or an earthquake or a flood. These are all issues that we're constantly dealing with. And only 6% of emergency departments across the country have the staff and equipment necessary to handle acute emergency pediatrics, even though close to 30% of their visits are from children. So, unfortunately, what's the daily experience? Doctors often send their patients to the emergency department because their schedules are full or they want to get them admitted to the hospital. But that can't be done directly because the inpatient beds may be full. So the patients come to the emergency department. We're all delighted to take care of them, but they have to stay there for a long time because there's just no other place to send them. So the staff has to divide its attention between the patients that are really admitted to the hospital and new patients that are constantly coming into the emergency department. So it's not uncommon, and I would say it's pretty often, that we may be extremely busy 24 hours a day, and we may be overwhelmed by the middle of the afternoon. And that makes for a bit of a stressful environment. It's hard on the patients, and we care most about you. It's hard on the staff. People aren't happy about that. I tell everybody when they come to work a shift in the emergency department to put on their track shoes and get ready to run, because that's what it is when it's busy down there. It's, for those of us for which there are no work regulations, the residents are in good shape because they're protected, but the faculty aren't. It's go to the bathroom at the beginning of your shift, eat your power bar, and we'll see you later. And we like it, but it can be difficult. Try something. Call your doctor and ask for an immediate appointment and see what happens. Okay? Unless you have a concierge physician whose office happens to be open when you happen to call, you will likely be told to go to the emergency department. How many people here have called and said, I don't feel well, and been told to go to the emergency department? Okay? I know I have. The primary care system in this country is struggling, and some people might say it's broken, because there isn't an effective intake system. There's not a way to match people up with their providers at a time when they don't feel well. When I entered the specialty of emergency medicine, there was a very strong notion that people should be kept out of the emergency department. If you look at the healthcare analyses that are done, people say, we strive to keep people out of the emergency department. It's an expensive place, there are too many tests done, and you should go see your primary care doctor. It'll be more cost-effective care. Well, I disagree a little bit. I don't think that it's reasonable to teach people economic lessons when they don't feel well. Just think about your emotions when you're hurt or you're sick and you want medical care. You want somebody to take care of you, and we're there to do that. And unless there's another place for you to go, we think it's important that you have a place to be able to go. 10% of people account for 70% of this nation's healthcare costs, but they suffer from chronic diseases, and when they're not feeling well, they have a limited ability to be practicing as informed consumers. It's just so difficult when you don't feel well and you're acutely ill to be able to peruse the internet or make 15 phone calls or make perfect choices. They need a place to go where they can be guided. So you all want the same thing we want. You want someone who will see you quickly, in whom you have confidence, who will take control of your situation, and who will make you feel better. Is there any other place in the healthcare system that accomplishes that more reliably than the emergency department on a regular basis? So we pride ourselves on being the frontline responders for natural disasters, mass casualty incidents, pandemics, episodes of terrorism, but we have to be able first to keep up with our day-to-day volume, and that's really important. And the reason that's important is there are laws that say that we have an obligation to treat everybody that comes to the emergency department. We cannot turn anyone away from the emergency department. It's actually against the law. So regardless of anybody's ability to pay, and that's because there were some horrible cases in the past where people were actually triaging people on their ability to pay, and there's none of that that can happen in this country, and it certainly would never happen at Stanford.